Hi there. So my name's Bethan Jones, and I'm one of the children's epilepsy nurses based in University Hospital Wales, and I work for the paediatric neurology team based here. So all I'm going to go over today is just some basic epilepsy awareness, different seizure types. I'll touch on some epilepsy medications, and I will also be touching on the VNS and the ketogenic diet. So, what is epilepsy? So epilepsy is the most common neurological condition in childhood. So it affects roughly 1 in every 200 children. So it's quite common. And it's caused by the brain cells becoming sort of overexcited. And it's this sort of burst of extra electrical activity with the brain cells become overexcited and is what causes someone to have a seizure. Um, and these seizures can present in many different types, depending on where within the brain that extra electrical activity is occurring. So there's symptomatic causes for seizures and also idiopathic. So they both account roughly for sort of 50-50%. So idiopathic is where we don't know why the seizures have started. So they just start for no apparent reason, and there's no reason for them. And then symptomatic. So these are causes then, like your genetic causes, your head injuries, encephalitis, certain infections can cause seizures, and certain syndromes will also cause seizures as well. It's just important to note you can have seizures when young children have a fever. These are called febrile convulsions. These are not epileptic. It's just the body's response to a fever, and they usually grow out of these types of seizures by the time they're about 5 years old. So types of seizures, you've got your focal, or they used to be called partial seizures, it's old terminology. So you've got your focal seizures where you're aware, or simple partials, what they used to be called. And you can also have focal seizures where you are not aware of what's going on around you. And focal seizures are contained to one part of the brain as well. So depending on where within the brain that focal seizure is occurring, will depend on how the seizure presents itself. So some people might have a funny taste in their mouth. Some people might sort of pick at their clothes. Other people might spin around in circles. They can do some quite strange things with focal seizures depending on where in the brain that seizure is occurring. And then you have your generalized seizures then. So these are seizures that affect the entire brain, so they cover the whole brain. So you have what's called myoclonic seizures, or your brief jerks. So these are quite, well, as it says, brief. When you think of when you're sort of going off to sleep, sometimes you can have that jerk when you're just going off. That's almost like a myoclonic jerk. But when somebody's having myoclonic seizures, they happen quite frequently and they can be quite annoying. Atonic then, so your drop attacks. So people that have these seizures will tend to wear a safety helmet because they're at really high risk of injury. The tonic-clonic then, so these are the sort of seizures that people think of when they think of epilepsy usually. So these are the big nasty seizures where you have shaking of all 4 limbs. You can have some blue tinging around the mouth, cyanosis. Some people will stop breathing. They're quite nasty seizures. Your absences. So these are like sudden lapses in consciousness. So they tend to last anywhere between about 10 to 15 seconds usually. They can go on longer in some cases, and these are called atypical absences because they go on longer than normal. But they, like I said, they tend to last for 10 to 15 seconds, and it's almost like a behavioural arrest. So the person will stop doing what they're doing and then just sort of come back in the room. And then you've got your tonic seizures as well then. So these are seizures where you basically just go completely stiff and rigid, and it's almost like a spasm of the body. So your tonic-clonic seizures then, or what used to be called a grand mal seizure. So there are 4 different phases you can have to a tonic-clonic seizure. So the first of those phases would be the aura phase. But it's important to note that not everyone will have the aura phase. So the aura is basically where they have some sort of feeling or sensation that they're going to have a seizure. Now, obviously, with young children, they're not going to be able to identify that that's an aura. But some people, once they sort of realise what the feeling is, they can link it to the fact that they're going to have a seizure. They might sit themselves down or put themselves in a safe position, ready for the seizure. And this can include like a funny taste in the mouth. Some people might have a really weird feeling in their stomach, or they might see some funny lights before they have a fit. And then you've got the tonic phase then. So the first phase of the tonic-clonic seizure is where you go completely stiff and rigid, and then that will then go into the clonic phase, which is the violent shaking of the limbs. After somebody has gone through the tonic-clonic phase of the seizure, then they'll go into what's called a postictal phase then. So they'll be really tired and they'll just want to go off to sleep. It's completely normal for somebody to be really sleepy afterwards. When you think of all that extra electrical activity that's just gone on within that person's brain, it's just going to completely wear them out. And some people might also find that they have a headache for a day or two after. They might just not feel quite themselves. And they might have some muscle aches as well, obviously from all that vigorous shaking. And some people will find that they might almost have a build up to a tonic-clonic seizure, so they might not feel quite themselves for a few days before they have a seizure, but again, that's not always the case. So then your absent seizures then, as I previously mentioned, it involves a sudden lapse in consciousness. So it's where they just basically stare off into space and they last between about 10 to 15 seconds on average. So these types of seizures are quite often picked up when a child starts school, because they can almost look like the child's daydreaming. You can have some sort of eyelid flickering and things as well with absent seizures. And there's no postictal phase with these either. So the person will have an absent seizure and then just sort of carry on with what they were doing before. They may well be a bit confused possibly afterwards if they were in the middle of saying something and then they have a seizure, an absent seizure. Or they might just carry on with what they were doing. And then your tonic seizures then, like I said, so you just go completely stiff. It's like a muscle spasm. And with these, you do tend to have impaired consciousness. You might, again, have some eyelid flickering. You might have some cyanosis with these as well. And these are quite nasty seizures. Your atonic then, so your sudden drops. Again, there's no postictal phase with these seizures, but there is a very high risk of injury, such as banging your head, which is why people that tend to have these seizures will have a safety helmet like this little boy has got on the right-hand side here. You maintain awareness throughout, so it's basically a really brief sort of where your muscles lose control. Basically, you drop to the floor and that's it. But again, they can be quite annoying if you're having frequent atonic seizures. And then you've got your myoclonic then, so your brief jerk. So if somebody's got something in their hand and they have a myoclonic seizure, they'll just drop with whatever they've got in their hand. Again, you maintain awareness with these and there's no postictal phase, so you're not sleepy or anything with these. But again, these are quite annoying seizures to have, quite frustrating. And again there, so that's just going over focal, generalized and unknown reasons for seizures. It's just important to note as well that if somebody has a focal seizure, they can then have what's called secondary generalization. So the seizure will start in one part of the brain and then it will spread then and turn into a generalized seizure, so it'll affect the entire brain. But then again, that's not always the case. So how do we diagnose epilepsy? So there's a couple of different ways that we will diagnose epilepsy. One of those is with what's called an EEG. So that is where we put all these little probes on the child's head, and you have what's called a standard EEG is what we would do first. So that tends to last about an hour. So we put all these probes on the child's head, and it basically looks to see if there are any extra or abnormal bursts of electrical activity going on within the brain corresponding with one of these probes here. If we get no joy with that, we can do what's called a 24-hour EEG, which is where the child comes in, we put the probes on the child's head, and then they are attached to like a little box. The child then goes home overnight with this box, and then they come back the next day to have all the probes taken away, and then the EEG is downloaded then. And that's quite good for seeing if there's any sort of pattern with the seizures, as in if somebody's having nocturnal seizures, or having seizures overnight, and it gives us more scope of catching something if we haven't caught anything on the EEG, the standard one. And you can also have what's called a video telemetry as well. So our children will usually go to Swansea, do them, and also there's places in England where we'll send our children. So we basically admit them for a few days. We'll reduce their anti-epileptic medication beforehand because we want to catch something basically when they're going for these video telemetries. They'll have all the probes fitted on their head like that, like in that picture. But they're also videoed at the same time. So it's looking to see if there's any electrical activity going on the EEG recording, whether that corresponds with any movement or any behaviours that are picked up via the video as well then. And like I said, that's usually an admission of a few days. And they have to stay in then, obviously, because we'll have to sort of increase their medication as well then, because we reduce them and they're at a higher risk of having a seizure. We'll also do an MRI or a CT scan. So this is to look for any structural causes for seizures, such as brain tumours or lesions within the brain. Video footage is really, really important for us. We love video footage because if we ask that they video the whole body as well. So we like to see what's going on in the face and the entire body. But it's really, really useful for us to be able to see what type of seizures or if there's seizures at all. And then family history is important. Blood, so we may do blood to check for any genetic causes, and we will take a history of the seizures as well. So when the seizures started, how frequent they're happening, what they look like, whether there's a family history, as I previously mentioned. We may do a urine sample, and if somebody has a seizure, they'll also have an ECG as well, because sometimes there can be cardiac causes for seizures, it's not always neurological. So if somebody has a seizure, they'll always have an ECG. So if somebody is having seizures, they will be followed up in clinic. So in Cardiff, this may not necessarily be under paediatric neurology. They may be followed up in general peds, and then started on medication if required. By the time they come to us in paediatric neurology, usually they've been tried on a few medications and it hasn't been successful in completely stopping the seizures. So that's usually at the point where we start seeing them. The schools and the GP and obviously anybody else that needs to be informed will be informed about the child and their seizures, and then a care plan will be drawn up if they are deemed that they need rescue medication such as buccal midazolam. So then I'm available for support or to train the parents or the schools or anybody that needs it really on how to deliver the emergency medication if it's prescribed. And then my role is also to be a support network, so parents can ring me up for any advice they want at all, do home visits, I do a lot of work within the schools as well then to support them. So anti-epileptic medication, that is a list of the anti-epileptic medications that are around. So things like sodium valproate and levetiracetam are probably two of the most common ones. Also things like glucosamide and lamotrigine are really common ones that we use. And brivaracetam, people will see a lot more of. So that's basically derived from the same family as levetiracetam or Keppra, but it is a much newer drug and it has less behavioural side effects. A lot of anti-epileptic medications have a lot of quite nasty side effects, so we don't like children being on more than one or two. Obviously some children do need to have more, but as I said, they do tend to all have quite nasty side effects with them. And then you've got the cannabidiol then there in red, which I've put in red because we can only give that to a very limited amount of patients that have undergone specific trials. So that's just a little graph there just showing how anti-epileptic meds have developed since the 1840s. So we do still use some of these really early ones like phenobarb and phenytoin. Ethosuximide, that's quite good for absent seizures. And then as you can see then, since about the 1980s, there's been a massive increase in the amount of anti-epileptic drugs that are available. So I'll just cover a couple of epilepsy syndromes now that you might come across. So the first of those would be Sturge-Weber syndrome. So that's characterized usually by a port wine stain on the face. And it's where the person has abnormal blood vessels on the surface of their brain. This condition is not usually genetic, so it usually occurs within the first 3 to 4 months of conception, and 2/3 of people with this condition will have seizures, and these are usually focal, and they can generalize. They're focal because they will occur sort of where this layer of abnormal blood vessels are, and then, as I said, it can generalize then into full seizures that affect the whole of the brain. It's quite common to have a hemiplegia. So a hemiplegia is a weakness on one side of the body. So if you've got a problem on the right-hand side of your brain, you're going to have, if that's going to present on the left-hand side of the body, the wires kind of cross. They tend to have learning difficulties, and people with this condition will often be resistant to anti-epileptic medication. So that there is a little baby with a port wine stain there. Lennox-Gastaut. So 1 in every 100 epileptic children will be affected with this, and this it is people with intractable seizures, so basically seizures that don't respond to medication. They'll have multiple seizure types and learning disability, and they'll have a really abnormal EEG as well when we stick the probes on to do the EEG. So the people with this condition are one of the conditions where we're actually able to give cannabidiol as a prescribed drug. And that there is an EEG of somebody who has Lennox-Gastaut syndrome. So that's really abnormal. So what we're looking for is nice smooth waves. Whereas you can see there that the lines are a bit everywhere, and there's activity. So each one of those little numbers there corresponds with a probe that's fitted on the head. So as you can see, there's activity actually going on every single probe, so every single part of the brain there. Angelman syndrome, so this is a genetic abnormality in chromosome 15, and it affects 1 in every 15,000 people, so it is rare. People with this condition, they'll appear really happy and smiley, like this girl here, and they tend to have really severe learning difficulties as well. They'll have bursts of sudden unexplained laughter, so this could be what's called gelastic seizures. So gelastic seizures are seizures where the person just laughs. They'll also have other multiple seizure types as well, and they have a lot of shaky, jerky movements. So people with this condition could be candidates for things like the VNS and the ketogenic diet too, to try and improve their seizures. And then Dravet syndrome. So this is a really, really nasty condition to have, characterized by catastrophic epilepsy. So usually starts with febrile convulsions. Seizures linked to fever, and it starts within the first year of life. Then these febrile convulsions turn into prolonged seizures, then multiple seizure types, and there's so much seizure activity that the person ends up having some developmental regression. They tend to be photosensitive, so it's just something to note that people with epilepsy, so only around about 10% of epileptic people will be photosensitive. People with Dravet will be photosensitive, so things like flashing lights, certain patterns can set them off, and environmental triggers. So again, that could be linked to the photosensitivity, or it could be things like the weather, like if the weather's too hot or if it's too cold, that can trigger them off. And it's caused in 8 out of 10 cases by mutation in the SCN1A gene. And again, it's really resistant to medication. And that there again then is an EEG of someone with Dravet. So there's a lot of activity going on all the time there. So triggers for seizures, a big one for us is lack of sleep or tiredness. So we bang on quite a lot about needing good sleep hygiene. So it's about going to bed at a regular bedtime. With our teenagers and things, we'll sort of advise them not to go on their phones and watching TV just before they go to sleep. But then the problem is that if you're having a lot of seizures, it'll affect your sleep. So it's a bit of a vicious cycle, because if you're having a lot of seizures, you're not going to sleep as well. And then because you're not sleeping as well, you're having a lot of seizures. But it is a biggie. if you're having better sleep, it does tend to help with seizure control. Illness as well, if somebody's feeling under the weather and they're poorly, then they're more likely to have more seizures. And girls, when they do on their period as well, so the spike in hormone will cause them to have more seizures, and these are called catamenial seizures. Stress can cause seizures and puberty, and then too much alcohol or recreational drugs. So precautions, we always advise people with a diagnosis of epilepsy to avoid baths. Ideally, we'd like them to completely avoid a bath altogether. But if they're really adamant that they want a bath, the only exception is if somebody else can either sit in the bathroom with them while they're having a bath, in case something happens, or they to have a bath with the door unlocked and somebody sort of standing by outside, and so at least if they do have a seizure, they can get in straight away. But ideally, it's a no for having a bath. You can still go swimming if you're epileptic, but you just need to make sure that the lifeguard knows, or that you're supervised when you're swimming. And you're not able to drive if you've had any type of seizure within 12 months. The DVLA won't let you drive. The only exception is if you only have nocturnal seizures. So if you only have ever had seizures at night, then you can sometimes drive. But apart from that, 12 months seizure free. And if you have a seizure, you have to report it to the DVLA. Supervision around hot appliances in the kitchen, and then safety helmets, obviously, if you're having your atonic seizures. So things that can help, there are quite a few things that we can use to try and help. So there are special alarms and devices that are available, such as there's like mats that go under the mattress that will detect seizures. There are alarms where there is like a bracelet that goes on the person's wrist, and that stays on them. And if they have a seizure, it'll send an alarm or notification to the parent's phone, so they know they're having a fit. Sleep hygiene, again, making sure that you've got a good sleep hygiene. And then you can also have seizure dogs then that are specifically trained to detect when somebody's having a seizure and to alert somebody that they need help. So the emergency care plans, so these care plans are given to children with a history of prolonged seizures, complex seizures, or a history following a seizure. So they're created in conjunction with the consultant, the family, and myself, if they're under paediatric neurology, and they're updated annually unless there's any changes. So the only reason why we would change that within the year is if that child's seizures change at all. So we try to keep it as accurate as possible. Once the care plan is created, we'll keep a copy in our files. A copy will go in the child's hospital notes, and then copies will be sent out to the parents, schools, etc., anybody who needs them. So the plan will contain the patient's details, so their name, date of birth, address. It'll have all their seizure types and a detailed description. So we try to make these care plans as detailed and as descriptive as possible, so that when somebody does have a seizure, whoever's looking at that plan knows exactly what they're looking at, and they can identify what type of seizure that child is having. And it'll also say whether that seizure, if a child is known to have focal and generalized seizures, again, we usually put a little title at the top of whether it is a focal or a generalized, or a focal seizure that generalizes, and then the description will be underneath. And we'll also put how long these seizures usually last. So on the second page, then you'll have when to administer the buccal midazolam and the correct dose to give. And some children will be able to have a second dose as well, so we'll also write that down on the care plan. So it'll tell you when the second dose can be given and at what point that second dose can be given. And it'll also tell you when to dial for an ambulance. So the care plan will also have the parent and guardian contact details on there so that they can be contacted. And it will tell you what to do if there's any issues in administering the emergency medication, and it'll have my contact details on there as well if you wish to contact me at all. So if a child has a seizure, some seizures, such as absences, we tend not to treat with emergency medication, but they still will be documented on the care plan. But the main thing really is if a child is having a big seizure, is try not to panic, which I know sometimes is easier said than done. But you need to make sure that you time it as well, because these emergency medications are given on a time basis. to call for help and remove anything that might be tight around that child's neck, and you place a cushion or something soft under their head if you can. If that child is in a wheelchair or strapped in, don't try and lift them out because you're going to hurt yourself or you're going to hurt them. And do not put anything in their mouths. Seizures are involuntary spasms of the muscles as well, so they're either going to bite down on you and really hurt you, or they can hurt themselves as well. So if they are vomiting or dribbling, they've got some secretions, if you can, roll them onto their side and just give their mouth a gentle little wipe so that anything that's sort of pooling will come out onto your cloth or your tissue. If that child then has an emergency care plan, you ask someone else to get it for you. You stay with that child, and somebody else needs to go and get the care plan for you, and then you just follow that. We try and make sure that they're quite easy to follow, and you would follow that then. If there is no plan, and the seizure is prolonged, or if the child is having a seizure, and it doesn't correspond with anything that's on that care plan, so it's a new type of seizure, then you would dial for 999. Just some extra stuff to mention about these care plans as well. So if the child has a VNS device inserted, then that will also be written on that child's care plan, because you usually use the VNS magnet in conjunction with giving the emergency medication. So it's really, really important to make sure that you always familiarise yourself with a child's care plan, especially if a child does have a VNS, because you'll commence swiping that VNS on the onset of the seizure as well. And there are some other drugs that will sometimes be on that person's care plan, such as epistatus or paraldehyde. So this is what we typically will prescribe for prolonged seizures. So it's your pre-filled buccal syringe, so you don't have to worry about drawing anything up. It's all there ready to go, and it'll have the right dose and everything written on that care plan for you to follow. And it is the parent's responsibility to make sure that that child's buccal is in date. So if you're in a school environment, it's their responsibility to make sure that you've got in-date buccal. Again, a very limited amount of our patients will be prescribed epistatus, and this tends to be used more for spasms. So we will also put, if a child suffers from spasms, sometimes we might prescribe them some epistatus as well. You've got to be really careful. They're both midazolam, but epistatus, you have to draw it up yourself. So you have to make sure that you have drawn up the correct dose of that. And it's just worth mentioning, so we don't use this, but this is a type of midazolam that's in circulation. Again, I don't think it's used widely at all within Wales, but it's just to be mindful in case you see a child moves into the area and has this. And it's just important to remember as well that epilepsy awareness or buccal training is required annually in order for you to remain up to date. So if the child's into paediatric neurology, you'd get in touch with myself and I will come out and deliver training. So even if you're really confident and you give him midazolam all the time, you still need to have your annual update. So I'll just go over the VNS quickly now, and then the ketogenic diet, and then we'll be finished. So VNS, so the vagus or vagal nerve stimulator, is a little device or a pulse generator that's fitted under a general anaesthetic. It's fitted under the skin on the left side, and then there's like little wires then that go up and they attach to the vagus nerve in the neck. And what it does is it sends regular mild electrical stimulations, and these stimulations go through the nerve and then go up to the brain. So it helps to stop irregular brain activity that leads to seizures. So why a VNS? We would refer somebody to have a VNS inserted if they've not responded very well to anti-epileptic medications. And it can be used to improve cognitive ability in those with certain conditions as well. So sometimes the VNS, even if it doesn't work massively well for seizure control in itself, a lot of people report better cognitive function or better behaviour. And it can help to reduce the length and intensity of seizures. So if somebody is prone to having some really nasty, violent seizures, they may still have the seizures, but what the VNS may do with these extra stimulations that go 24 hours a day, it may help to sort of calm that seizure down so it's not as aggressive and not as violent when it happens. And it can reduce recovery time. So it may reduce the amount of time that somebody is kind of in that postictal phase after a seizure. It can also be used in adults as a mood stabilizer. So adults with really severe depression, it's been proven to help stabilize their mood. And that's basically what it looks like. So you've got your little pulse generator here, you've got your wires then that go up and then they attach to the nerve. Once this is in, so the little battery there can be changed, but the wires stay in place. You don't change those wires once they're in. So it can take up to 2 years to work properly, so it's not a quick fix. So we make sure that parents are aware of this when we start the referral process for that person to have a VNS. And it's no use in people with physical findings on an MRI. So if somebody's got a lesion or a structural cause for their seizures, then fitting a VNS is not going to make any difference. So those people will be candidates for epilepsy surgery, or to have that lesion or tumor or whatever removed, if possible. They're used in conjunction with anti-epileptic drugs. So if you have a really good response with the VNS, once we've sort of ramped you up, then you can think then over time about starting to gradually reduce some of these anti-epileptic medications. You can still swim and shower and everything once you've got a VNS in place. The only thing you can't have is an MRI of your head or neck, just because of the metal work there once it's inserted, and it can last up to about 10 years, but this is dependent on the model. So there's different models of the pulse generators, and it depends how strong we've got the stimulation going through as well, or if you're needing to swipe the VNS frequently, then obviously it's going to use up the battery a bit quicker, but that's something that we check when they come to see us in neurology clinic. And it's really important that stimulator, so that little thing that is put under the skin there, that is replaced before the battery runs out. So if somebody's got really, really good control, thanks to the VNS, if we leave that battery, that pulse generator run out, then it's really, really difficult to get that level of control back. It takes a long time to build someone up with the VNS, and once you've lost that control, you might never get that same level of control back again. So they'll come to see us in clinic, and we can actually see how much battery is left on it. So then we will refer to neurosurgical team here in Cardiff, and then they will have that pulse generator changed. So this wand here, we sort of wave over the skin where this pulse generator is, and then it'll bring up all the details on this little tablet that we have. So it'll tell us how often the VNS is going off. It'll tell us how often it's been swiped. So we can kind of see a pattern of what times a day maybe somebody's having a seizure or how frequently. And it gives us an idea of whether or not we need to do what we call ramping up as well. So ramping up is the term we use for slowly and gradually increasing the amount of stimulation to gain optimum effect. So it's usually done in regular clinic visits with the patient, the consultant, and myself. And with the new devices that have come out recently, you can actually ramp the child up in 6 stages without needing to come and see us in clinic. So they have really close contact with us, so that we can make sure that everything is going okay. But we've got patients obviously that live quite a long way away, so this is really useful so that they don't have to travel all the way down to Cardiff. We can just set it to go up at certain intervals in 6 stages, and then any problems, they just ring us, and we can sort them out then. And then it's increased the amount of stimulation that's delivered by that pulse generator is increased as tolerated by the patient, and there are certain guidelines that we have to follow as well with ramping them up. So what to look out for if we've ramped a child up and we've increased the amount of stimulation going through that pulse generator, then they might cough quite a lot, or they might do like a clearing of their throat. And you would tend to find there's a bit of a pattern with this. So if it's going off, if we've set it to go off every minute, then they would sort of cough or clear their throat around every minute, you'd notice. Some people will complain of shortness of breath if it's a bit too strong for them, and some problems swallowing. And it can also make your voice sound really hoarse as well. And these are all things that you would see as a result of the strength of the stimulation being a bit too much for them at that point. So what we would do is just reduce it slightly and then build it up at a slower rate. Increase in seizures, so you would tend to just find that if that person their VNS is running out of battery, or if for whatever reason there's been a problem, and that sometimes the pulse generator can just break, although this is really rare. So it's really simple for people to use. So every child, once they've had a VNS inserted, they should have 2 magnets, which look like this, and you can get some nice fancy little bands nowadays as well, to pop the magnet on. And there's also a clip on the back of the magnet as well, so you don't necessarily have to keep it on the wristband. You can clip it onto something. They're really, really strong magnets, so it's just useful to know if you are working with a child with a VNS, don't put the magnet near your phone, or don't put it near credit cards and things like that, because it'll just zap them. You have to feel for the magnet, so you're feeling for the magnet on the chest, and then you swipe it in a cross motion. So you wait 1 minute and then you swipe again. And as I previously mentioned with regards to the care plans, it'll state on the care plan how often you're doing this. There's no point just swiping, because it won't do anything. It's just pointless. And the rationale for doing the cross motion is that you should definitely have swiped over the magnet at that point. So you swipe in once in a cross motion once you've felt for that device. You're waiting for a minute and then you're swiping again. So for example, if a child's got an emergency care plan for buccal midazolam, it may say to swipe once a minute for 5 minutes, and then on that 5th minute you're giving the buccal midazolam. And then what we will say is to continue swiping once a minute until you can either give a second dose or ring for an ambulance. And you would swipe the VNS on the onset of the seizure as well, so you're not waiting like you do with midazolam. If a child starts fitting and they've got a VNS, you swipe. So that's basically it with the VNS, just a basic thing on that. And now I'll just talk about the ketogenic diet briefly, and then we'll be finished. So Matthew's Friends is just one of the charities that we use to support with children on the diet. So what the ketogenic basically is, it is a really, really high fat diet, low carb, really low carb. And it's established treatment option for pediatrics. Unfortunately, there is no service for the ketogenic diet in adults, which is a massive pain, because it really does work sometimes. It can be a really good form of treatment. We are here for tertiary support in paediatric neurology in Cardiff, but it's mainly managed by the ketogenic dietitians based in Bristol Children's Hospital. So they come down every 3 months to Cardiff to do a clinic, but the families are in close contact with the ketogenic dietitians at all times. It's, like I said, it's extremely strict. So the food is literally weighed out to the gram, and they are individualized to that child. We don't know exactly how it works or why it works, we just know that it does. But it basically changes the way that your body metabolizes energy. So where we metabolize energy through our carbohydrates, by stripping that person of the carbohydrates, you're tricking the body into thinking that it's starving, and you produce something called ketones then. So you basically metabolize energy through fat. So you need daily BM and ketone testing, and basically it was found that when people were coming into hospital when they were poorly, obviously when you're feeling really under the weather, you don't want to eat, and they just found that people were not having as many seizures, and that was because the ketones were going up, and for whatever reason that was stopping the patients having as many seizures. So once they're referred or started on the diet, they need to have 6 monthly bloods, so we check everything. And they, as I said, they come to see us every 3 months in clinic with the dietitians. They have really, really strict diet plans. And if they're admitted into hospital, then it's really, really important. If that child needs fluids, you do not give them dextrose. Because the whole point is that you don't give them sugar and carbs and things. The minute they have dextrose in their IV fluids, you're knocking them out of ketosis. So they'll probably be quite poorly, they feel really rubbish. And you might find even that they have more seizures because that dextrose has completely whacked them out of ketosis. they should have a sticker on their hospital notes to say that that child is on the diet and not to give them dextrose. And if a child is admitted into hospital, for those of you that work within the hospital, you can always give me a call, and I can give you some advice if needed. And it can be used in any age group. And it's also just important just to note, if the child's in school, obviously if they even so much as have like a biscuit or a sweet, it's going to knock them out to ketosis. So it really is that strict. So the benefits of the ketogenic diet is seizure reduction. So over half of children have a 50% reduction in seizures, and 10 to 15% of those children will become seizure free. And a lot of people note that there's better cognitive function as well. So children that may not have much speech in that previously, you may find that they start speaking more, or they just look better sometimes, and they start doing more. They're more interested in what's around them. And it is the only known treatment for a metabolic condition called GLUT1 deficiency. So your brain needs glucose to function, basically, and it's a problem with the sort of transportation system there. So the only treatment for that condition is the diet. And it also can give people increased energy levels. So the side effects or negatives of the diet is you're more likely to have kidney stones. So we'll do an ultrasound of that person's kidneys to make sure that they're not developing kidney stones. And we don't like them usually to be on the diet for more than about 4 years, although obviously in some cases, especially obviously if they've got GLUT1 deficiency, they'll be on that diet for longer. And also you tend to find once a child's been on the diet, if it's been proven really effective, and after 4 years, say, we'll take them off the diet, it's a permanent change. So once you take them off the diet, you'll find sometimes once they've been on for a certain amount of time, that whatever changes have been made from starting it, they stay, if that makes sense. You can, when you first start, you do feel really, really rubbish, because obviously you're changing the way your body metabolizes energy, so you can get quite sick, you can feel hungry, and you're actually more likely to have weight loss. You'd think that you'd gain weight because you're eating all that fat, but you're actually more likely to lose weight because your body's using all that fat as energy. Non-compliance as well. So if you've got a child that's used to eating a normal diet, it's quite hard for them then, because they can't eat all the things that they'd usually eat. If you've got a child that is PEG fed or NG fed, it's a lot easier, because you can just put the feed up, and then they're getting everything they need via that feed. But obviously, like I said, if that child has one sweet or one biscuit, then it's going to knock them out ketosis. You can also have constipation due to a lack of fibre in the diet, and it's a complete lifestyle change. So you really need to apply yourself as a family if your child is going on the diet. People tend to sort of set one day aside for like meal prep and things, where they'll make all the meals for the week. Things have changed a lot in the last few years. You can get some sort of nice cookbooks and things now, but again, they all tend to come from the ketogenic dietitians. So there's 2 types of diet. This is the last bit now, and then we're done. So you have what's called the classic diet, which is the one we tend to use. So it's based on a ratio of ketone producing foods. So your ketone producing foods are your fats, to foods that reduce ketone production, so carbs and protein. So we usually give them on a 3-to-1 ratio. So you'll have 3 lots of ketone producing foods such as fat, butter, etc., to 1 portion of carbs or protein. And 87% of the energy in the classic diet is provided by fats. So you are eating a lot of butter, a lot of mayo, marge, oil, cream, really, really high fat. And then your proteins will come from, again, high fat sort of foods like your cheese, fish, and eggs. And the only carbs you'll have, so you won't have things like potatoes and that, your only carbs will tend to be from your vegetables and your fruit. And then you've got your MCT, or medium chain triglyceride diet, which was developed in the 70s as an alternative to the classic. So basically enable people to fit a few more carbs and proteins into the diet. So your MCT, so your medium chain triglycerides, are a type of fat that's usually found in butter and oil. And you have to take that in the form of a supplement, and you take it with every meal and every snack that you have. And like I said, it just allows for more proteins and more carbohydrates to be incorporated into the diet, and it's provided with every meal. There is an increased risk of gastrointestinal problems with this diet, and then 30 to 60% of your fats will be provided from your MCT fats. There have been randomized controlled trials done to try and see if there are any benefits between using the MCT diet as opposed to the classic diet, and they haven't really found any benefit from using one to the other. It just gives the person chance to fit a few more carbs and proteins in, like I said. And that's it really. So these are my contact details. If you ever wish to contact me, my email address and my contact number. And you can contact me for any advice, any info that you need. All right, so thank you very much for listening.